So thanks for hanging in there until the end of the day. I'm going to be talking about pediatric renal tumors. And pediatric renal tumor, the most important factor to consider when developing a differential diagnosis for pediatric renal tumors is the age of the patient. And renal tumors can be broadly categorized as those that occur in the first decade of life and those that occur in the second decade of life. I'm not going to be talking about all of the tumors that are listed here. I'm going to be focusing on the ones that we see at our institution and you'll probably see in your practices and those that are important in the pediatric oncology setting. So to begin with the first decade, renal tumors, I'm not going to spend much time talking about Wilms tumor because I think we all know a lot about that already. Instead, I'd like to talk about the ones that are less common and the important features of them in pediatric oncology. Even though some of these tumors are very rare, if you're doing a lot of pediatric imaging, you're going to come across these tumors. So to begin with, we all know Wilms tumor is the most common renal tumor in children. It arises from metanephric tissue. The peak age incidence is from 3 to 4 years of age. Most patients have a favorable histology and an excellent prognosis. Those with an anaplastic histology, however, do have a poor prognosis. Most of these patients will present with an asymptomatic palpable abdominal mass, oftentimes that is noticed by a parent. On imaging, they appear as large, solid intrarenal masses that distort the renal parenchyma, displace but don't encase vessels. They can invade the renal vein, IVC, and right atrium, and they metastasize to the lung, liver, and nodes. One thing I want to stress is the importance of recognizing tumor rupture in these tumors because this will upstage the patient. So it's important to recognize when a tumor is ruptured. And on imaging, there are several features, including perinephric stranding or fuzziness around the tumor margin, retroperitoneal fluid, and pelvic fluid that extends beyond the cul-de-sac. These have all been reported as being true signs of tumor rupture. Of course, always important to look for IVC thrombus, which can be small, as shown here, or can be very extensive, as shown here, expanding the IVC, growing into the hepatic veins, and up into the right atrium. So cystic nephroma and partially differentiated cystic nephroma, previously this was referred to as multilocular cystic nephroma, but the terminology changed to indicate the neoplastic nature of this tumor. It also arises from metanephric tissue like Wilms tumor and is now felt to represent a spectrum of disease in differentiation from the benign cystic nephroma to the malignant Wilms tumor and nephroblastoma. And this is similar to what we see with neuroblastoma, where there's a spectrum from ganglioneuroma to neuroblastoma. And in between cystic nephroma and Wilms tumor is partially differentiated cystic nephroma. So clinically, these patients present at, in a younger age group than the typical Wilms tumor, but they do overlap the age range of Wilms tumor. And they can look like a multicystic dysplastic kidney on imaging. Multicystic dysplastic kidney, however, is going to be present at birth and is often diagnosed prenatally. Just like Wilms tumor, these can present as an asymptomatic palpable mass. They can herniate into the renal pelvis and cause hematuria. And importantly, it's important to remember their association with DICER1 mutation and their association with cystic pleural pulmonary blastoma, like we've already heard from Dr. Voss. On imaging, we cannot distinguish between a cystic nephroma and a partially differentiated cystic nephroma. They look identical. The difference between these is what their septa are composed of. They both appear as well circumscribed encapsulated multicystic masses with no nodular or solid component. So this is an example of a 3-month-old. Again, this is a very young patient with DICER1 mutation and the cystic pleural pulmonary blastoma, and another patient with DICER1 mutation, a 3-year-old who was found to have this cystic nephroma on surveillance ultrasound. On ultrasound, you can identify all the septa and the simple cysts. There may be areas in these tumors that appear solid on ultrasound, but this is because the cysts in those areas are so small, they're below the resolution of the ultrasound transducer. So this was another patient with DICER1 mutation who had bilateral cystic nephromas. Because the septa are composed of fibrous tissue, they appear dark on all imaging sequences, and they will enhance after administration of contrast material, but there should be no solid component to any part of these tumors. Congenital mesoblastic nephroma is the most common renal tumor in infants. Most of these are diagnosed very early in life, before 3 months of age, but almost always before 1 year of age. There are 3 histologic types: the classic type, the cellular type, and the mixed classic and cellular type. The cellular type tend to be a little larger and occur at a little later age. They have a genetic abnormality that is identical to infantile fibrosarcoma, and they have a biologic behavior that's just like infantile fibrosarcoma. They're highly likely to harbor NTRK fusions, which are absent in the classic type. So the biologic behavior of these tumors, the classic type is entirely benign. The cellular type, however, can exhibit an aggressive behavior. 5 to 10% of these tumors will develop a local recurrence or metastasize to the lung, to the liver, to the bone, or to the brain. And even though they can metastasize, they have an excellent survival, just like infantile fibrosarcoma. So this is an example of a 6-day-old boy who had a prenatal ultrasound that showed a solid intrarenal mass, and also had this area within it that appeared necrotic. And the presence of necrosis or cystic areas within these masses is a feature that's associated with the cellular type of mesoplastic nephroma, but not with the classic type. So this is an imaging feature that can tip you off that this is a cellular type of mesoplastic nephroma. So this patient actually presented 15 months later with limping. This X-ray was obtained that showed this destructive lesion in the distal tibia. On MRI, it appeared as a large soft tissue mass with cortical destruction. The tumor had the TRK mutation, and the patient was treated with a targeted TRK inhibitor therapy, had an excellent response, had reconstitution of the bony cortex around the marrow, and is now in complete remission and has an excellent prognosis. Clear cell sarcoma of the kidney, also known as bone metastasizing renal tumor of childhood, has a peak age incidence that overlaps that of Wilms, but again occurs sometimes in younger patients than the typical Wilms. There are no reports of this being bilateral disease. This behaves more aggressively than Wilms tumor. These patients have a poorer prognosis than patients with Wilms tumor. It can metastasize to the bones, lymph nodes, brain, liver, and lungs. On imaging, there's really no imaging feature that can tip you off that you're looking at a clear cell sarcoma. They look just like Wilms tumor. So if I see something that looks like a Wilms tumor in a very young patient, I usually include clear cell sarcoma in my differential. This is a 10-month-old boy with a clear cell sarcoma. Again, this was a very young patient, so unlikely to have Wilms tumor, but the imaging of the right renal tumor is very similar to what we see with Wilms tumor. And in this case, there's free fluid in the retroperitoneum, so this tumor had already ruptured. And the patient had brain metastasis at the time of diagnosis. This was a 2-year-old boy with a clear cell sarcoma. Again, we have this large left intrarenal mass with areas of necrosis that looks very similar to a Wilms tumor. Rhabdoid tumor is a highly aggressive tumor that occurs exclusively in children. The majority of these patients are diagnosed very early in life, usually between 6 and 12 months of age, the vast majority before 2 years of age. This tumor has an association with brain tumors that can occur either synchronously or metachronously, the most common of which is intracranial atypical teratoid rhabdoid tumor, which is a midline posterior fossa tumor. This is the most aggressive pediatric renal malignancy. These tumors metastasize early, and most patients will ultimately develop metastases, most commonly to the lungs, but also to the liver, to elsewhere in the abdomen, to the brain, to lymph nodes, and to bones. Their survival is very poor. On imaging, they appear as large, centrally located masses, often involving the renal hilum. There are a few unique features in these tumors that sometimes can tip you off to their diagnosis. And these include subcapsular fluid and tumor lobules that are separated by fluid or outlined by linear calcifications. So if I see a tumor with these imaging features in a very young patient, I include rhabdoid tumor in my differential. So this was a patient sent to our institution, again, a very young patient, who had this non-contrast enhanced CT scan performed at an outside institution. And I'm not an advocate of non-contrast enhanced CT. I don't think it has any value in children. But in this case, it did demonstrate the linear calcifications that can sometimes be seen in these tumors that outline tumor nodules. And then after the administration of contrast, you can appreciate the very lobulated nature of this mass and that the lobules are separated by fluid, features that are said to be typical of rhabdoid. This patient developed pleural and pulmonary disease just 7 months after his diagnosis. This was another patient, a 7-month-old, again a very young patient, presented with seizures and had this atypical teratoid rhabdoid tumor in the posterior fossa. 10 months later, developed metachronous left renal tumor and pulmonary metastatic disease. This was another patient, again a very young patient, only 18 months old, had this ultrasound done showing this solid mass in the right kidney and this subcapsular fluid collection, which is a unique feature of rhabdoid tumor, seen better here by CT. So we have this centrally located tumor with this subcapsular fluid collection. So switching now to tumors that arise in the second decade, the most common are the ones that we see at our institution are renal cell carcinoma, lymphoma, and peripheral neuroepithelial tumor or Ewing sarcoma. So renal cell carcinoma is the second most common renal tumor in children. In the first decade of life, a Wilms tumor is going to have an incidence that's 30 times that of a renal cell carcinoma. But in the second decade of life, they have a 1-to-1 incidence. The subtypes of renal cell carcinoma in children are different than those in adults. The most common type in adults is a clear cell carcinoma. In children, it's translocation carcinoma, followed by papillary carcinoma and medullary carcinoma. So translocation renal cell carcinoma comprises a third to half of all pediatric renal cell carcinomas. It's often an incidental finding that's seen on imaging that's obtained for other reasons. The patients can present with flank pain and hematuria. It's due to a translocation that leads to a TFE3 protein overexpression, so it's often referred to as a TFE3 translocation renal cell carcinoma. And importantly, chemotherapy in childhood, during childhood, is a risk factor for developing these tumors. They often have an indolent course and can be very advanced when they're first diagnosed. They metastasize to lymph nodes, lung, and liver. On imaging, they can appear as heterogeneous hemorrhagic or necrotic masses, but they often contain calcification. And the presence of calcification in these masses can help differentiate them from the other types of renal cell carcinoma, which do not contain calcification. These are usually smaller masses that are centered in the medulla and completely contained in the kidney. Nodal involvement is very common in this tumor type, and it's easy to miss nodal involvement by imaging. Even if we use a short axis diameter of 1 centimeter, we only detect about 25% of involved nodes in these patients. It's very important for the surgeons when they resect these tumors to do nodal sampling to correctly stage the patient. So this is an example of a 5-year-old boy who had been treated at our institution for leukemia. This is imaging that was obtained as a bone mineral density CT scan. We do a lot of these. These are very low-dose CT scans that are done without any contrast material, just for purposes of measuring the density in the lumbar spine. And in this case, it was noted that this patient had this small rounded mass in the right kidney that contained calcification. This was confirmed by ultrasound. You can see the small round mass in the kidney that's containing calcification, and also by CT. So these tumors tend to be smaller. They tend to be completely contained within the kidney and often contain calcification. So medullary renal carcinoma is a tumor that occurs in adolescents and young adults with sickle cell trait. It can be seen in patients with sickle cell disease and even Caucasians, but most patients will have sickle cell trait. So if you see a renal tumor in an adolescent boy who is of African descent, think of medullary renal carcinoma. It's 3 times more common in boys than in girls in this age group. Patients can present with gross hematuria and flank pain. This is an infiltrative and aggressive tumor, and it's often advanced at the time of diagnosis. On imaging, for some reason, these tumors have a predilection for the right kidney. They're often centrally located, oftentimes either abutting the renal pelvis or directly invading the renal pelvis. They also invade the retroperitoneum. Local lymph node invasion is very common in up to 80% of cases. They can invade the renal vein and directly invade the liver. They usually are smaller than Wilms tumor. They metastasize hematogenously to the liver and commonly to the lungs. So this was a 12-year-old boy with sickle cell trait who had painless hematuria, had this right renal tumor with this associated adenopathy due to invasion in the local lymph nodes, which is common in this tumor. This was a 16-year-old boy with sickle cell trait, presented with painless hematuria, had this centrally located solid mass. The central location is very common in these tumors. And by CT, you can see that the tumor is invading the renal pelvis and collecting system. In a recent study from the Children's Oncology Group, another unique feature of medullary renal cell carcinoma was the presence of lymphatic pulmonary metastatic disease as opposed to distinct pulmonary nodules. This pattern of pulmonary metastatic disease was seen in about half of patients who presented with pulmonary metastatic disease. It has this appearance of diffuse bilateral interstitial disease, seen here. Another example taken from that article. These patients can present with respiratory distress. That can be their presenting feature. And on their CT imaging features can be mistaken for pulmonary edema or pneumonia. So important to keep in mind that this is a pattern of metastatic disease as well in this tumor. Oftentimes when patients have the pulmonary lymphatic spread, they also have mediastinal and hilar adenopathy, just a reflection of the propensity of this tumor to spread through the lymphatics. Lymphoma, moving on to lymphoma, non-Hodgkin lymphoma is much more likely to involve the kidneys than Hodgkin lymphoma. Interestingly, at autopsy, 62% of patients with non-Hodgkin lymphoma have renal involvement, but by imaging, only a small minority, 3 to 8% of patients show renal involvement on CT. These are usually asymptomatic until late in the disease, and they can present with flank pain and hematuria, anemia, and weight loss. On imaging, they can present as either solitary or multiple masses or diffusely infiltrate the kidneys. They can directly invade contiguous structures. They can invade into the perinephric tissue. And isolated renal disease without nodal disease or other disease is very, very rare, but it can happen. And this is an example of a case, a 5-year-old boy who was sent to our institution with a diagnosis of bilateral Wilms tumor. You can see that this tumor is diffusely involving the inferior poles, middle and inferior poles of the kidneys, as well as having more discrete masses. You'll also note that this tumor was invading directly into the perinephric tissue. He was treated for bilateral Wilms tumor and actually had a really good response to therapy. He went on to have bilateral partial nephrectomies, at which time it was realized that he actually had B-cell lymphoma. But the more common appearance and presentation of these patients will be with bilateral renal masses or renal involvement and evidence of disease elsewhere. In this patient with Burkitt lymphoma, there's thickening of the wall of the stomach, there's involvement of the pancreas, and there's pericardial nodal disease. And Burkitt lymphoma is the most common lymphoma to involve the kidneys. Moving next to primitive neuroectodermal tumor, PNET. I don't have a lot to say about this. I just wanted everyone to be aware that this is very rare, but Ewing sarcoma can arise primarily in the kidneys. It doesn't occur just in bone and extraosseous soft tissue sites. It can also arise in the kidney. These patients are usually older adolescents or young adults. This is an aggressive tumor. It metastasizes to the lung, liver, and bone in 30 to 50% of cases. On imaging, it's typically a large, heterogeneous, hemorrhagic, and necrotic mass that's poorly defined. It can invade the renal vein and the IVC. This was an example of an 18-year-old girl that is currently being treated at our hospital with this large right renal tumor that invaded the right renal vein and the IVC, and she had metastatic, bilateral pulmonary metastatic disease at the time of diagnosis with a right pneumothorax. So in conclusion, age is the most important factor to consider when you're developing a differential for renal tumors in children. In the first decade, the most common tumor in children, in infants, is congenital mesoblastic nephroma. Remember that there are subtypes of mesoblastic nephroma, and the cellular subtype can show aggressive behavior and may metastasize, but they are genetically identical to infantile fibrosarcoma, and these patients actually have a very good prognosis. In the very young years, 0 to 2 years of life, consider rhabdoid tumor and clear cell sarcoma. In the 2 to 4 year age group, cystic nephroma, partially differentiated nephroma, cystic nephroma, Wilms tumor, and clear cell sarcoma. Remember that cystic nephroma has an association with DICER1 mutation and cystic pulmonary pleural pulmonary blastoma. In the second decade of life, the most common are renal cell carcinoma, lymphoma, and rarely Ewing sarcoma. TFE3, translocation renal cell carcinoma, is the most common, and a history of prior chemotherapy is a risk factor for developing these tumors. And if you have an adolescent boy who has sickle cell trait or is of African descent, consider renal medullary carcinoma. And I thank you for your attention.